Hi, my name is Mitch. I'm with Jared, Luke, and Wyatt, and today we're reviewing a case and comparing it to the collaborative normal tension glaucoma study.
All right, case overview. We had a 68-year-old Caucasian woman. She was diagnosed with normal tension glaucoma in the right eye and considered just a high-risk glaucoma suspect in the left eye. Her normal pressures were 18 millimeters of mercury in her right and 15 millimeters of mercury in her left. Her risk factors for normal tension glaucoma included migraines, Raynaud's phenomenon, systemic hypertension, thin central corneas, a family history of glaucoma, and myopia. So if we take a look at her fundus images, where we expect to see some damage here, we see in her right eye the glaucomatous cupping of the optic nerve and some thin inferior normal rim thinning. You can really appreciate that with the vessels kind of drooping down to the bottom there, showing that thinning. And we also see a large disc hemorrhage present at the 8 o'clock region. Her left eye was actually pretty nice. It only had slight vertical elongation of the cup, no disc hemorrhages, and only a choroidal present.
If we look at her RNFL thickness maps, in the right eye we're seeing some inferior thinning of the RNFL in both that T-snake curve and the RNFL quadrant clock hours, whereas in the left eye it's within normal limits, but we are seeing some mild inferior nasal thinning.
And the inferior thinning in the right eye can be seen in the visual field as the superior arcuate defect, as well as the glaucoma hemifield test being outside normal limits, is what leads us to our glaucoma diagnosis. And in the left eye, showing scattered shallow nasal defects, but the glaucoma hemifield test is within normal limits.
Quick overview about glaucoma and normal tension glaucoma. So glaucoma we know is a progressive optic neuropathy that typically involves visual field loss, and our main modifying factor for glaucoma is IOPs. With normal tension glaucoma, we observe optic nerve change without any increase in eye pressures. So normal tension glaucoma patients never have a documented IOP greater than 21 in either eye. And with normal tension glaucoma, our management is the same as all other types of glaucoma. Our goal is to prevent functional vision loss.
And how this case relates to our study, her normal tension glaucoma findings, her arcuate field defect, the nerve fiber layer thinning, the optic disc cupping, as well as her vascular risk factors, such as Raynaud's, low blood pressure, and migraines, coincide with our diagnosis. And the management standards of our goal IOP being approximately 30% reduced from her tested IOP from 18 to 13, as well as her visual field defect showing progression that threatens her fixation.
So our diagnosis, low tension glaucoma in the right eye, high risk glaucoma suspect in the left eye. Our plan for this patient, we educated them on the exam findings today and educated them on their target IOPs and treatment plan that we'll go into on a future slide. We want the patient to return to our clinic in 1 month for an IOP check once we get them started on treatment, and then also come back in 6 months to repeat visual field testing to help determine our baseline fields. And right now we're going to be beginning medical therapy in the right eye. How did our assessment plan correlate with our study? So the study did suggest that even if the intraocular pressures are within the normal limits of 10 to 21, it is still a contributing factor to optic nerve damage. Diagnosing this glaucomatous change without the increase in pressures is crucial for our treatment. The requirements for this study involved every patient never having IOPs greater than 24 and having some sort of optic disc abnormality and visual field defect correlating to the change. Our patient fit all three of these requirements, so it is safe to say that we can compare our case to the results of the study when determining how to treat. Our study also expressed the importance of other risk factors outside of pressures like gender, disc abnormalities, migraines, race. Ultimately, we made our decision to diagnose low tension glaucoma based off of the factors listed above and the results of our study. We deemed it necessary to begin medical treatment to slow the progression of the disease.
So our treatment plan for our patient, we decided we're going to initiate treatment with alpha-GMP 3 times a day in that right eye only. Our goal is to cut down that 18 millimeters of mercury in the right eye to 13. We're going to continue to monitor closely in the left eye with no treatment. We educated the patient on side effects of alpha-GMP, which include dry mouth, headaches, fatigue, and drowsiness. And we are considering referral for laser trabeculoplasty if the treatment goal is not met with that topical therapy. Now, in relation to our study, a drop from 18 to 13 in the IOP would be roughly a 30% reduction, which our study states that when IOP is lowered by 30%, The disease showed a slower rate of visual field progression compared to eyes with no treatment. However, this treatment must be vigorous since it is more difficult to lower pressures substantially that are already reasonably low.
For how we could handle this case differently, an alternative treatment could be going to latanoprost in both eyes, as it has a slightly better IOP reduction capabilities, and based on her previously mentioned risk factors, she's likely to progress in that left eye, so treating both eyes could be an alternative treatment.
All right, if we look at some of the important conclusions from the study, not only was our patient female, she also was experiencing migraines and had a prominent optic disc hemorrhage. If you look at the baseline factors associated with the progression of normal tinge glaucoma, you are 2.5 times more likely to progress due to migraines, 2.7 times more likely to progress due to hemorrhages, and 1.5 or 8 times more likely to progress due to gender. So if we are comparing our study to other landmark studies, we can see that in our case, we actually measured the central corneal thickness to be 493 microns in her right and 497 microns in the left. One of the biggest issues with our study was we didn't actually factor in corneal thickness, whereas the hypertension study did find that to be an independent risk factor and a very important determination of glaucoma. So if you look at their numbers, they said that the mean central corneal thickness for those who developed primary open-angle glaucoma was 553 microns, which our patient fell well below, and the mean central corneal thickness for those who did not develop primary open-angle glaucoma was 574 microns. So basically all this concludes is that with her, corneal thicknesses puts her at a 3 times greater risk of developing primary open-angle glaucoma.
Thank you for your time.